Ken Landau. Thanks for watching. Let's talk about Entresto. Entresto is a drug released by the Food and Drug Administration in 2015 to reduce the number of hospitalizations and reduce the number of people who die from cardiac disease in people who have congestive heart failure or simply heart failure. Treatments for the disorder have typically been an ACE inhibitor like enalapril or lisinopril in combination with Coreg, beta blocker, or metoprolol, and spironolactone oftentimes, and a diuretic. But sometimes people can't take the ACE inhibitor, can't take the lisinopril or the enalapril, because it makes them cough. So they take an ARB, an angiotensin receptor blocker, instead, a drug like Diovan. Well, heart failure is rated either class 1, 2, 3, or 4. This drug is for class 2, 3, or 4. That's the majority of the patients. Class 2, people have mild symptoms. They have mild shortness of breath, mild angina. They're slightly limited as to their ordinary activities. Class 3, more severely limited. You can only walk a short distance, but you're comfortable at rest. Class 4, you're not even comfortable at rest. You're basically housebound, bedbound, or chairbound. People who have congestive heart failure complain of shortness of breath, wheezing because fluid building up inside the lungs, or fatigue, or swelling of the lower legs or the ankles or the feet, difficulty lying flat, difficulty sleeping, difficulty with their appetite. They complain of abdominal pain or swelling. It's unfortunate that this condition is common, affecting about 5 million people in the United States. 85% of the people have reduced ejection fraction. Normally, the heart would pump out more than 50% of the fluid in the chambers, but in congestive heart failure, typically it produces or pumps out less than 40%. This condition, heart failure, causes 100,000 hospitalizations every year. While the condition can resolve, more likely it's going to become not only chronic, but progressive. And as the heart deteriorates, it causes major chemical changes inside the body, and those chemical changes are maladaptive. They cause other kind of problems that cause a vicious cycle. Well, the Diovan, the angiotensin receptor blocker that we talked about a moment ago, is actually in the Entresto. The way the Diovan works is it causes the smooth muscle cells to relax, and it reduces the amount of aldosterone, so it reduces the amount of salt in the system. It allows more oxygenated blood to flow to the different tissues, and it reduces the amount of extracellular volume, so the heart doesn't have to work as hard. So all of that is good. The other component of the Entresto is a neprilysin inhibitor. Now, neprilysin is a normal enzyme found in the body, and it breaks down certain substances, and these substances are actually important in people who have congestive heart failure. So we don't want to break them down so much. So the Sacubirtil, which is the other component, along with the Diovan, in the Entresto, it works to, again, decrease the constriction of the vessels, decrease the sodium, but it also helps reduce the maladaptive remodeling that goes on inside the heart. So when you have congestive heart failure, it actually negatively affects the heart, less so when you take this particular drug. Now, the Sacubirtil itself isn't an active drug. It has to be metabolized inside the body to sacubitril-A, and that's the active component. Now, up until recently, congestive heart failure has been treated with cheap, inexpensive generic drugs. The cornerstone of therapy has been the enalapril and the lisinopril since the late 1980s, early 1990s. Now we have this new drug, and we have a big study, and the study was called Paradigm HF, stands for heart failure, of course. And what they did is they evaluated the Entresto, remember the combination of Diovan and Sacubirtil. They compared that, one pill twice a day, to taking an ACE inhibitor, the enalapril, 10 milligrams twice a day. That's not even the maximum dose. It is the maximum dose of Diovan, however, and that's in addition to taking all the other standard medicines in both groups. Now, additionally, there are some peculiarities of the study that make it hard to accept. One of the peculiarities is that the people had to have heart failure, had to be treated for at least a month before they would even enter the study, had to be treated with an ACE inhibitor or a drug like Diovan, and the maximum tolerated doses of a beta blocker had a normal blood pressure of over 100. When the people were evaluated for the study, about 70% of them had ejection fraction of 35% or less. Remember, 50% or more is normal. Additionally, why did the people have heart failure? They had it because of coronary artery disease, too much plaque, or they had it because of chronic high blood pressure, maybe a heart attack. Some of them had diabetes. People were taking an awful lot of drugs. The study itself was a double-blind study, and it evaluated people who mostly had class 2 heart failure. Remember, slight shortness of breath, slight angina, slight limitation in normal activities. 70% of them in that group. More significant problems, class 3, in about 25% of the patients. Well, actually, the overall ejection fraction was little less than 30%. Peculiarly, 2/3 of the people in the study were white, 5% were black, 20% were Asian, and the average age was 64. Problem already. Here in the United States, that's not the mix of patients that would be average in the cardiologist's office. The patients would be older, a smaller percent would be Caucasian, and a greater percent would be black. Additionally, this study of 8,400 patients of a very common condition, 5% of the patients were in the United States, 95% of the patients were out of the United States, 20% were in Western Europe, Central Europe and Eastern Europe and Russia accounted for 33% of the patients, Latin America about 1 in 6 patients, and almost 1 in 5 patients in Asia or the Pacific area. Now, the countries involved in the study were Turkey and Venezuela and Hungary and Mexico and Russia and the Philippines and Peru and the Dominican Republic and Argentina and China and South Africa and Brazil. Some of these sites were so bad that they had to get kicked out. And not only that, so you had to have the symptoms of heart failure for at least a month. But then to get into the study, you had to take the enalapril for 2 weeks. Then you would stop it for a day. Then you would take the Entresto, first at 100 milligrams twice a day, then 200 milligrams twice a day. You would do that for 4 to 6 weeks. And then if everything was okay and the study didn't exclude you, you didn't have side effects, you weren't dropped for any other reason, then you could enter the study. Well, already we have a situation where 10% of the people receiving the enalapril and then 10% of the people receiving the Entresto were dropped from the study for one reason or another. So only 80% of the people who started out get into the study. So when we talk about side effects, now we don't really have good information because we've already excluded a bunch of patients. And then while they were on the therapy, once they got into the study, another 10 or 20% dropped out. Now, the goal of the study was to follow the people for several years. But they stopped the study early at 27 months. Why did they stop it at 27 months? They stopped it because they said, we already see significant benefits. But the problem is when you stop studies too short, you don't know if those early benefits are going to be maintained, and especially in a condition where you're going to take the drug basically for the rest of your life. We would like more than 27 months of therapy. Now, they say that there was a 20% reduction in the likelihood of either hospitalization or cardiovascular related death, but that's a relative number. The absolute numbers in Entresto, 21.8% of the people had some kind of event. Among people taking just the Vasotec, it was 26.5%. So when they talk about a 20% reduction, what they really mean is about a 5% reduction. Supposedly, there were benefits, and it didn't matter your age, your race, your sex, your kidney status, whether you were diabetic or not, didn't make any difference. But when we look at the data, we find actually the highest incidence of hospitalization and death happened here in North America. The lowest in Western Europe. There was an increased death rate in Latin America and the Asian and Pacific countries, and actually there was decreased hospitalization in Europe compared to the United States. And for some peculiar reason, the incidence of atrial fibrillation in the two groups, the group receiving the Entresto and the group receiving the enalapril, was equal. Should not have been. Dr. Stephen Nesson from the Cleveland Clinic, very eminent cardiologist, thinks this is a breakthrough. On the other hand, another doctor writing in the British Medical Journal blog, the report of the Institute for Clinical and Economic Review, said, we got some issues with this study. We really can't tell what the risk-benefit ratio is because of the peculiarity of the study. It isn't the kind of a study that has to do with the patients who are sitting in the doctor's waiting room. It has nothing to do with the kind of people that we normally see. And additionally, the people who received the Entresto had a lower blood pressure by 3 millimeters, and that's significant. So a 3 millimeter reduction in the blood pressure receiving maximum dose of Diovan in the Entresto group compared to an average dose of enalapril in the other group, seems like we're not really dealing with the match. Why didn't they study if the Entresto is a combination of Diovan and a neprilysin inhibitor? Why didn't they study that, the Entresto, versus Diovan by itself, and then you could study it against the enalapril? Well, this has been hyped as the major advance in congestive heart failure in the past 20 years. But unfortunately, there are so many questions about the study and the way the study was organized and the way the study was developed, and the fact that there were only a very small number of patients who were black that were studied, that we don't have any idea what the outcome would be for them. And they tend to respond poorly to ACE inhibitors and angiotensin receptor blockers. And then we have a study that was done in 47 different countries. Remember, this is a common disease. We have 5 million people here in the United States with congestive heart failure. So they had to go to 47 different countries and 1,000 plus different sites? Come on. And it was funded by Novartis, the drug company. They collected the data. They managed the data, analyzed the data. They haven't supplied the raw data to independent investigators. You have a significant number of dropouts who were in that run-up that we talked about. You would have to treat at least 35 patients for at least 2.5 years to prevent one significant complication. And the fact that there wasn't a smaller incidence of atrial fibrillation in the Entresto group is very disturbing. And remember, we have a 3 millimeter decrease in the systolic blood pressure, and we know a 2 millimeter decrease can give us a 7% reduction in cardiovascular-related deaths. So that is significant. We have eliminated over 2,000 people from the study. The Sacubirtil actually could have been a sugar pill. Remember, in the combination with the Entresto, we have the Diovan and the Sacubirtil. Well, if the Diovan was just pushing the blood pressure down extra, that could account for the entire benefit. But that has not been studied. So we need a second study now to confirm this study that might not have been the best study in the entire world. And we also know that there were significant differences in outcome. And some of the differences in outcome might have to do with the treatment that was different. So in the United States, about half of the people had an intracardiac defibrillator, as opposed to only about 2% of the people in China and in the Philippines. And if we look at the mineralocorticoids, well, we used them here in the United States in about a third of the patients, but it was about 2/3 of the patients in Latin America. And the benefits actually were seen only in the class 1 and class 2 heart failure. They were not seen in the class 3 and the class 4 heart failure. The benefit of taking Entresto is you can take it twice a day. You can take it with food or without food. There's a black box warning that says, hey, if you're a pregnant woman, don't take this drug. But again, congestive heart failure is not typically in that age group. But if you are pregnant, you definitely shouldn't be taking this drug, and especially if you happen to be in your second or third trimester, or if you're breastfeeding. Side effects include hypotension, the blood pressure going down too much, the potassium going up too much, sometimes the kidney function deteriorating, sometimes developing swelling. Shouldn't take it with drugs that tend to hold on to potassium in your body. You have to be especially cautious if you're diabetic or if you have some kidney problems. Shouldn't take it with aspirin or naproxen or ibuprofen because of accumulating renal disease. Got to be very cautious of that. Can cause some lithium toxicity if you're taking lithium because you have bipolar disorder. If you take it with Viagra, your blood pressure might go through the floor and your sodium can be reduced while you take this. So there's another problem that hasn't been really discussed. Naproxen breaks down some of the amyloid in the brain. So if this drug, the Entresto, specifically the Sacubirtil, if it blocks the breakdown of the amyloid inside the brain, the question is, does that lead to Alzheimer's disease? The company says no, but it really hasn't been studied. But we do know in some of the laboratory animals that were studied, if we knock out the gene for naproxen, then yes, indeed, amyloid plaques do form inside the brain and neurobehavioral abnormalities do develop. So the Food and Drug Administration said, yeah, we'll let you put the drug on the market, but you folks at Novartis better do a study and show us for sure that it's not going to lead to Alzheimer's disease down the road. Well, additionally, the company argues that we didn't do the study with Diovan by itself and compare it to the Entresto because Diovan hasn't been shown to work, but it hasn't been studied. So they ought to go do the study. And we also know that when a drug company funds a big study, or even a small study, that there's always potential for hanky-panky. It makes people nervous. It would be wonderful if the study was funded by a different group that didn't have an interest in the outcome. And the reason that we don't want the drug company to fund the study is, in this particular study, 4 of the authors were employees of the company, and the company reviewed and edited the paper. And now they claim it's beneficial for class 2, 3, and 4 heart failure, but the study suggests it probably is only really of benefit in class 2 heart failure. And another problem is it hasn't been studied in people who have symptomatic heart failure, unstable patients. And as a matter of fact, it hasn't been studied in people who have heart failure because they just had a heart attack. New onset heart failure. All of the patients who were studied, remember, were studied because they had heart failure, they were on therapy for at least a month, and then they went through a month of enalapril and then a month of the Entresto, and then they were randomized to the study. Too much problem. And when we're talking about Novartis, Novartis got into a heck of a lot of trouble over a study of Diovan. Remember, Diovan is basically half of what's in the Entresto. Well, they got in trouble in Japan because they were doing some hanky-panky with the Kyoto University and the Kyoto Heart Study that they were sponsoring. The problem was so severe that the university had to retract 8 papers in international cardiology journals, all because of problems with Novartis. And Novartis is in trouble right now in Greece, and they're in trouble right now in China, and they're in trouble right now in New York State for the False Claims Act. The company can't understand why the drug didn't have a better start. They thought this was going to be a gangbuster right out of the open. But it wasn't. And the reason it wasn't is it's too expensive. Cardiologists were used to using other drugs, the standard therapies. This is a marked change. And the insurance companies were not used to paying these exorbitant prices for a drug. Now, the drug has been heavily advertised on the television. They expected originally that the drug would bring in a peak of almost $7 billion a year, but they reduced it now because it had such a slow opening, reduced it to about a max of $3 billion a year by 2026. They've had to negotiate with insurance companies. They give rebates, or some people would call them kickbacks or something, to the insurance company and guarantee them that on top of the regular rebate, they'll give them even more if the drug doesn't seem more beneficial than some of the other therapies, if it doesn't reduce the number of hospitalizations or cardiac-related deaths. How much the drug cost? $16 or $17 a day, $6,000 a year, $500 a month, $600, something like that, depending on what drugstore you would go to. If you happen to have a drug company copay card, it could be as little as $10 a month out of your pocket. But if you look at where the money is coming from, it's not that you're paying $10 that gets you the drug. Your insurance company is paying a pretty penny. Compare that, $16, $17 a day, to, say, the generic of Diovan, cost you about $20 a month. So, what do we have? We have a study that was done in 1,000+ different sites in 47 countries by a drug company that's been questionable in some of its activities. We have a study where patients are not the kind of patients who typically are seen in the doctor's offices, and we have benefits that have been shown in one study that was cut short after 27 months. So do we have definitive evidence that this is the drug for heart failure? I'd submit to you that at the present time, the answer is unknown. Anyway, thanks for watching. I'm Dr. Ken Landau.